So today we're talking about doing tracheostomies, and it's important to know that you have the right equipment and material. I have three different tracheostomy tubes in here, and the regular ones, these are the Shileys. This is an 8 and a 6, and we also occasionally, for larger folks with a big thick neck, need what's called a Shiley XLT. So the Shiley XLT has a longer tubing to fit into somebody that has a really thick neck, or the distance to the trachea or the windpipe is longer. And then here's a collar. Usually we don't really need this necessarily because we use the straps that come in here. And I'm going to should I come closer for the view of this tube? Because I need to open this and show folks. So here's the packaging. This is a Shiley 6 DCT. That stands for dual cannula tube. I'm going to open this one to show you. Here's the package, and here are the things that come inside the package. And of course, you know that your circulator in the room will be making sure that all these things get logged and charged. So here's what comes in this package. There are, this is what we use to tie the tube in. We usually suture it in place if it's a fresh trach. This is called the obturator, and this is the inner cannula. So we remove this, and then to place the tube, we have the obturator in place. And then the person who's helping needs to verify that this is holding air. And so you fill this with air and verify that this is okay. You can place it under saline, make sure there's no leaks, and then once you verify that yes, this is in fact working, you would deflate so it goes back to the way that it came out of the package. Obturator is in place. So once the tube is placed by the surgeon, this will come out. This stays and goes with the patient, and then you place the inner cannula, which then snaps in position in here. And at that point we would be suturing the device. So normally the surgeon would be on this side of the patient. An assistant might be holding our handy-dandy Army Navies, typically positioned above the head on the side, opening up the pathway into the trachea. And so one here, and then pull the other one from this side. Yeah. So like that. And they keep the midline. Other instruments that we might use, I like to use a Cushing's with teeth once I get to the level of the trachea. It's important not to use cautery once you have entered the airway, and usually we ask anesthesia if you're going to use even bipolar after you've made an incision in the trachea because of the fire risk with oxygen. Make sure that anesthesia has the oxygen level turned down to 30%. If it's higher than 30%, we just need to know that, and for sure not use any kind of cautery or bipolar near the airway. When it comes time, all the dissections have been made, the trach is exposed. Very important to communicate with the anesthesia team what we're about to do, that we have the proper help. Then we typically use a 15 blade to make the cut in the tracheostomy, and we use sutures. Some people use stay sutures. It would use actually silk or nylon sutures through the trachea. I use a chromic. I make a little window and then suture that flap of that window to the soft tissues in the neck, and that just keeps that in place. Once that's done, we ask anesthesia to pull their tube back, stop ventilating, and then we would get our tracheostomy tube with the obturator. This has been tested, and we place it into the right spot. And there it is. Take the obturator, we keep this, this goes with the patient, and now place this. We would need to blow up the cuff. So here's the syringe. We've blown up the cuff. The patient has been stable all throughout this, as anesthesia has told us, and now they connect here and we ventilate. It's important then to still hold on to this tube in here until we secure it. Then we would take some silk sutures and suture this to the skin and then apply the ties. And a job well done, everybody.